In this video, we will discuss the role of pelvic floor trigger point injections in the management of chronic myofascial pelvic pain. We have no disclosures or conflicts of interest to report. This is an example of a patient that may present to an outpatient clinic visit for a consult. JD is a 28-year-old G1P1 who presents with dyspareunia and constipation. Her past medical history is notable for endometriosis, chronic pelvic pain, depression, and migraines. With further conversation, she screens positive for a trauma history notable for physical abuse in childhood. She has had one prior surgery, which was a C-section at the age of 24. She is currently taking a combination of prescribed and over-the-counter medications to address her pelvic pain. A pelvic exam performed in the office demonstrated concern for myofascial pelvic pain and, in particular, the presence of myofascial trigger points. External genitalia were normal, without any lesions or erythema noted. Her bimanual exam was overall unremarkable, with a normally sized mobile uterus, no cervical motion, tenderness, and no adnexal tenderness. Examination of the pelvic floor muscles isolated increased tone and tenderness of the levator ani muscles bilaterally, with reproducible pain at the 3 o'clock and 9 o'clock positions. Further chart review demonstrated that this patient had previously tried to manage her symptoms with a combination of pelvic floor physical therapy, biofeedback with service electromyography, and manual therapy via massage. JD is an example of 1 in 7 patients who suffer from chronic pelvic pain. Myofascial pelvic pain is an important, albeit neglected, component of this condition that has been reported in up to 14 to 23% of patients. Myofascial pain syndrome is defined as chronic, non-articular, local musculoskeletal pain that manifests as muscle and connective tissue tenderness within the pelvic floor muscles, more specifically the levator ani and obturator internus. Myofascial trigger points are intrinsic to myofascial pelvic pain. They manifest as nodules in palpable, taut muscular bands that are sensitive to pressure and stiffer than surrounding tissue. Risk factors for development of trigger points can fall into mechanical or inflammatory mechanisms. Mechanical risk factors include examples of physical trauma, such as prior pelvic surgery, birth trauma, repetitive movement patterns, and a history of abuse. Inflammatory risk factors include endometriosis, fibromyalgia, and pelvic inflammatory disease. Patients may present with a wide range of symptoms, including pelvic pain, dyspareunia, abdominal pain, back pain, urinary urgency, and dyschezia. In order to accurately assess, diagnose, and manage this condition, knowledge of pelvic floor anatomy is imperative. The first layer of pelvic floor muscles are superficial and aim to support as well as to anchor the deeper muscles to the pelvic girdle. Specific muscle layers are identified by landmarks corresponding to the index or middle finger used during examination. Using the hymenal ring as the reference point, the first layer of superficial pelvic floor muscles corresponds to the depth of the nail bed. This marks the location of the perineal body, external anal sphincter, superficial transverse perineal muscle, ischiocavernosus muscle, bulbospongiosus muscle, perineal membrane, and perineal muscle. The middle knuckle depth corresponds to the second layer of superficial pelvic muscles, which is associated with the location of the deep transverse perineal muscles inferiorly and the urethral muscles superiorly. Beyond the middle knuckle and up to the length of the examining finger are the deep pelvic floor muscles that form the levator ani. In addition to providing support to the pelvic visceral structures, the levator ani plays an important role in urinary voiding, defecation, and sexual function. It is formed by 3 main pelvic floor muscles. The puborectalis originates from the posterior surface of the pubis and forms a U-shaped sling around the anal canal before attaching to the pubis on the contralateral side. The pubococcygeus muscles are found between the 1 and 5 o'clock and the 7 and 11 o'clock positions and stretch from the pubic bone to the coccyx, ultimately supporting pelvic organs. The iliococcygeus is found between the 4 and 8 o'clock positions, forming the posterior lateral part of the levator ani muscle group. The obturator internus arises from the inner surface of the anterolateral wall of the pelvis and surrounds the obturator foramen. An internal exam for the levator ani muscles involves placement of a single index finger within the vagina at the 5 o'clock and 7 o'clock positions just beyond the level of the hymen. An around-the-clock method can be used to palpate superficial, intermediate, and deep layer muscles according to the depth of the finger in relation to the hymenal ring as described previously. The obturator internus muscles can then be evaluated by hooking the index finger around the pubic rami starting at the right side and proceeding counterclockwise to the left obturator internus. One therapeutic intervention is the trigger point injection. This technique involves either a Pudendal block kit or a 22-gauge spinal needle with the sheath of the spinal needle used for guidance. The thought is that direct mechanical stimulation and hydrodissection of tight bands surrounding nerve fibers may play a role in connective tissue remodeling, which can then induce plasticity to interrupt the myofascial trigger point pathway. The Pudendal block kit typically includes a trumpet needle guide, 20-gauge spinal needle with spacer, and a 10 cc syringe. The needle is inserted through the trumpet needle guide. The syringe is then attached, and the anesthetic agent of choice can be injected. Botox is typically dosed with 100 units in 10 cc's of preservative-free saline and injected in 1 cc aliquots. Alternatively, anesthetic agents can be used, such as 10 cc's of bupivacaine in 2.5 cc aliquots. The sheath can additionally be trimmed to expose 1 to 1.5 centimeters of the needle. Regarding levator ani trigger points, the needle is inserted inferiorly and medially to the ischial tuberosities and is guided towards a finger placed transvaginally. This may elicit a local twitch response. The syringe should be aspirated, then local anesthetic is injected. Regarding the obturator internus trigger points, the needle is inserted along the obturator internus muscle belly posteriorly and guided towards a finger placed transvaginally between the ischial spine and ischial tuberosity. The aforementioned technique of aspiration prior to injection is subsequently performed. In patients with pain along the pudendal territory or with vulvodynia, we can offer pudendal nerve blocks. The pudendal nerve is formed from the sacral plexus, which is a network of nerve fibers located on the posterior pelvic wall that arises from the ventral rami. Within the gluteal region, it bends along the sacrospinous ligament lying proximal to the ischial spine throughout its path. After exiting the lesser sciatic foramen, it enters the perineum and runs through a sheath of connective tissue called the Alcock's canal on the medial wall of the obturator internus. The pudendal nerve block involves a solution of 10 cc's of 0.25% bupivacaine with 0.5 cc's of triamcinolone 40. This solution is injected in 5 cc aliquots approximately 1 centimeter caudal and medial to each ischial spine. This is important to avoid pudendal vessels, which can cause hematoma formation and retroperitoneal bleeding from the terminal branch of the anterior trunk of the internal iliac. Several studies have considered the efficacy of trigger point injections. A retrospective study published in 2017 included 68 patients with chronic pelvic pain and myofascial pelvic pain refractory to medical management. After receiving trigger point injections, up to 65% of patients had improvement in pain scores. 25% of patients required repeat injections, and the median time interval for repeating treatment was approximately 1.5 months. A randomized trial published by Zurab et al. Compared trigger point injections to physical therapy among patients with myofascial pelvic pain and dyspareunia. The time to improvement was shorter among those who received trigger point injections, with an estimate of 4.4 weeks compared to those who received physical therapy and required up to 7.3 weeks for improvement. Finally, a recent systematic review and meta-analysis published by Meister et al. Included 9 studies and 257 patients to more comprehensively examine this form of management. The authors noted statistically significant improvement in pain scores for patients who received trigger point injections at the 6-week and 12-week time points. In summary, up to 1 in 7 patients experience chronic pelvic pain, and myofascial trigger points are an important manifestation of this condition. They are intrinsic to myofascial pelvic pain. A comprehensive external and internal exam is necessary to identify trigger points in the levator ani muscles and obturator internus that can benefit from intervention. One such management technique involves injection of Botox or anesthetic into trigger points that can help with symptom management. Pudendal nerve blocks can similarly be performed to aid with vulvodynia or pain along the pudendal territory.